The world community has known of the Ebola virus disease, more commonly called just Ebola, since it first appeared in a remote region near the Democratic Republic of Congo in 1976. In previous outbreaks, Ebola has been confined to remote areas in which there was little contact outside the villages in which it appeared. Unfortunately, this outbreak, now an epidemic, spread from village to an international center for regional trade and spread into urban areas in Guinea, Sierra Leone, and Liberia that are crowded with limited medical services and limited resident trust of government. The unprecedented West African Ebola epidemic has not only killed more than 5,000 people, with more than 14,000 others known to be affected, this situation has skewed the planning for how to deal with the outbreak. In our two previous hearings on the Ebola epidemic, an emergency hearing we held on August 7th, and then a follow-up on September 17th, we heard about the worsening rates of infection and challenges in responding to this form from government agencies such as USAID and CDC, and NGOs operating on the ground such as Samaritan's Purse and SAM. Today's hearing is intended to take testimony from non-governmental organizations providing services on the ground currently in the affected countries, especially Liberia, so we can better determine how proposed actions are being implemented. In its early stages, Ebola manifests the same symptoms as less immediately deadly diseases such as malaria, which means initial healthcare workers have been unprepared for the deadly nature of the disease that they have been asked to treat. This meant that too many healthcare workers, national and international, have been at risk in treating patients who themselves may not know they have Ebola. Hundreds of healthcare workers have been infected, and many have died, including some of the top medical personnel in the three affected countries. What we found quite quickly was that the healthcare systems in these countries, despite heavy investment by the United States and other donors, remain weak. As it happens, there are three countries, either coming out of very divisive civil conflict or experiencing serious political divisions. Consequently, citizens have not been widely prepared to accept recommendations from their own governments. For quite some time, many people in all three countries would not accept that the Ebola epidemic was real. Even now, it is believed that despite the prevalence of burial teams throughout Liberia, for example, some families are reluctant to identify their sufferings and dead loved ones for safe burials, which places family members and their neighbors at heightened risk of contracting this often fatal disease when patients are most contagious. The porous borders of these three countries have allowed people to cross between countries at will. This may facilitate commerce, which is a good thing, but it also allows for diseases to be transmitted regionally. As a result, the prevalence of Ebola in these three countries has ebbed and flowed with the migration of people from one country to the other. Liberia remains the hardest hit of the three countries, with more than 6,500 Ebola cases officially recorded, probably a significant understatement. The number of infected and dead from Ebola could be as much as 3 times, however, than the official figure due to underreporting. Organizations operating on the ground have told us over the past 5 months that despite the increasing reach of international and national efforts to contact those affected with Ebola, there remains many remote areas where it is still difficult to find residents or gain sufficient trust to obtain their cooperation. Consequently, the ebb and flow in infection continues. Even when it looks like the battle is being won, in one place it increases in a neighboring country or region and then reignites in the areas that look to be successes. The United States is focusing on Liberia, the UK is focusing on Sierra Leone, and France and the European Union are supposed to be focusing on Guinea. In both Sierra Leone and Guinea, the anti-Ebola efforts are behind the pace of those in Liberia. This epidemic must be brought under control in all three if our efforts are to be successful. Last week, I, along with Congresswoman Karen Bass and Congressman Mark Meadows of this subcommittee, introduced H.R. 5710, the Ebola Emergency Response Act. This bill lays out steps that needed for the U.S. government to effectively help fight the West African Ebola epidemic, especially in Liberia, the worst hit of the three countries. This includes recruiting and training healthcare personnel, establishing fully functional treatment centers, conducting education campaigns among populations in affected countries, and developing diagnostics, treatments, and vaccines. H.R. 5710 confirms U.S. policy in the anti-Ebola fight and provides necessary authorities for the administration to continue or expand anticipated actions in this regard. The bill encourages U.S. collaboration with other donors to mitigate the risk of economic collapse and civil unrest in the 3 affected countries. Furthermore, the legislation authorizes funding of the International Disaster Assistance Account at the higher FY 2014 level to effectively support these anti-Ebola efforts. I'd like to now turn to my friend and colleague, Ms. Bass, for any opening comments you might have.